Good morning, everybody. We're going to start the morning session of the second day of our conference. So we start with the first lecture, Evaluation of Diplopia, What is Life-Threatening, by Dr. Lee.
Hi. I'm going to talk to you about some life-threatening causes of diplopia and how to recognize them. One is arteritis, which you're going to hear about in a diplopia standpoint, which is a little bit different than what Dr. Svina talked about. Apoplexy, abscess, fungal abscess, mucor in particular, aneurysm from people involved third nerve palsy, and arterial dissection. For diplopia, it's going to be vertebral, but you should also be aware that carotid dissection can be a problem. And these are Lee's P's. These are the red flags that should tell you that whatever the patient's diplopia cause is could be potentially dangerous. Pain, especially if you hear that it's the worst pain they've ever had in their life, or if they're an elderly patient, you want to be thinking about giant cell. And I'll tell you why you still have to think about giant cell in Kuwait, even though you don't have it endemic in your population necessarily. Perception loss, by that I mean an optic neuropathy, pupil involvement, progressive proptosis, and paresthesia, and obviously paralysis, systemic findings of vertebral dissection, which we'll cover. So the behavior change that hopefully you'll make is to tell your techs that when they receive the call about double vision, most of the calls that we receive about double vision are benign. About half of them are monocular diplopia, and I don't even accept those patients. So from a screening standpoint, it's useful for my triage techs to know what to take and what not to take. And these are the things that should trigger just come now. Acute painful ophthalmoplegia, acute painful bitemporal hymenopsia, acute painful anisocoria, either a small pupil or a big pupil, acute painful vision loss in the elderly, that's giant cell, acute painful bilateral disc edema, that's papilledema until proven otherwise, acute no light perception vision, that's almost always badness. There are very few things in this world that cause you to be acutely NLP, and the worst headache of my life. Now, what does this have to do with the diplopia list? Well, if any of these questions are answered yes in the setting of the complaint of diplopia, that is an emergency. So first we'll talk about giant cell. Everyone knows what Dr. Savino already told you. Elderly patient, often female, headache, jaw claudication, temporal artery pain, neck pain. Everybody knows that. And usually the complaint that brings them to the ophthalmologist is loss of vision from ischemic optic neuropathy. They have an elevated cell-rate CRP. We do the biopsy and treat them with steroids. Everyone knows that. But the thing you should also know about giant cell is that transient diplopia is a symptom. In the Hayway data, about 5 to 6% of the patients had transient diplopia somewhere in their history. Now, it may not have been the predominant complaint, but it was in there. So any ophthalmoplegia in the elderly person, you should think about giant cell. I'm not saying that a classic ocular motor isolated ischemic palsy should have a SED rate and CRP. I don't do that for my patients, but I do what Dr. Savino told you yesterday, which is ask the questions in elderly patients with diplopia about giant cell. And those questions are headache, jaw pain, neck pain, polymyalgia rheumatica, jaw claudication, the usual suspects. This patient's complaint was transient diplopia, and I said, well, what's that thing on the side of your head? She said, this thing? That thing's been hurting me for a week. It's a garden hose on the side of her head. That's giant cell arteritis. And you'd think that giant cell, at least in the United States, would not be misdiagnosed, but this is from a series from the rheumatology literature, and you can see 146 biopsy-proven giant cells. 23 of them, 16% of the cohort, lost their vision, and they had giant cell arteritis symptoms on average 1.3 months. 35% of the cases had polymyalgia rheumatica, proximal hip and shoulder girdle pain, for an average of 10.8 months. And 65%, and this is the important part, had premonitory visual symptoms, either amyloidosis fugax or transient diplopia, on average for 8.5 days prior to the ischemic optic neuropathy that took their vision. So there was a clear delay in diagnosis in 65% of the patients that lost their vision. On average, in my practice, most of my patients with giant cell have seen at least 2 and sometimes 3 or more doctors before coming to me, and no diagnosis is made. Everyone in the front row probably has similar stories. They've been to the dentist, the chiropractor, the neurologist, the internal medicine doc, no diagnosis made. And giant cell can kill you, and the way it kills you is it is a systemic vasculitis, and there's certainly been evidence for aortitis. It's not as high in my practice as in the Mayo Clinic data, but certainly if you look at mortality versus age-matched controls, giant cell does kill people. So, why should you care about giant cell in Kuwait? At dinner last night, I heard from one of our oculoplastics colleagues that they had only done 5 biopsies we do 5 biopsies in 2 weeks at Methodist Hospital, and he had 0 positives. Well, the reason you should care about giant cell in Kuwait is, of course, because of the multinational nature of your population, and Western diseases come to see you. So even though you don't have Western diseases in your endemic population, Western diseases are coming to visit you. Let's switch gears and talk about this 22-year-old woman who's presenting with severe headache and new onset diplopia. She's referred as a quote-unquote partial third, but 2050 is the recorded vision by the tech, and my tech writes next to it, effort. And the chief complaint is not blurred vision, but the diplopia. They do this Humphrey, and it comes out completely black, and my resident writes next to it, unreliable. In your part of the world, it's Thursday, 4:45 p.m. In our part of the world, that would say Friday, 4:45 p.m. So one of the messages that you heard about was performing a visual field, and I think at the very minimum, all patients deserve an 8-point examination and evaluation, even if their chief complaint is diplopia. And one of the things that drives me nuts about our residents is they'll write unreliable next to the visual field. That's the same thing as writing, I have no visual field on this patient. Writing unreliable is the same as saying you don't have any information about the field. And so in the setting of a bitemporal hemianopsia, new onset diplopia is a suprasellar lesion until proven otherwise. And in the setting of an acute painful ophthalmoplegia, that's apoplexy. So one of the things that I'm trying to get all residents to think about is the suprasellar space doesn't just pick one symptom to present with at a time. If it goes straight up, it hits the body of the chiasm, yes, bitemporal hemianopsia. But if it just goes a little bit anterior, it'll hit one optic nerve, unilateral optic neuropathy. If it hits both optic nerves, bilateral optic neuropathy. If it just goes a little bit posterior, it'll hit the tract and cause a homonymous hemianopsia. If it chooses to go laterally instead of superiorly, you'll get ophthalmoplegia. And third nerve palsy, as it turns out, is a relatively common presentation of pituitary apoplexy. And so one of the errors that is made very easily is thinking that pituitary lesions equal bitemporal hemianopsia. That's true, but any neuro-ophthalmic presentation, whether it's ptosis, big pupil, small pupil, bitemporal hemianopsia, unilateral optic neuropathy, or homonymous hemianopsia, can all be suprasellar mass lesions from pituitary apoplexy in the acute setting. And pituitary tumors are quite common, perhaps as high as 7 per 100,000. The older you get, the more likely you are to have it. Some estimates are 1 in 500 for age over 65. And my friend Derek Katz used to say the average ophthalmologist should see 1 pituitary tumor per year. Are you missing your quota? So the classic presentation of apoplexy. Apoplexy means apoplectic, comes on acutely. It's usually associated with severe headache, but not always. Although the books say bitemporal hemianopsia, the thing I want you to take home from this talk on apoplexy is if it goes laterally, it'll present with ophthalmoplegia, and partial third nerve palsy, in my experience, is a very common presentation, even though you would think that sixth nerve palsy would be the most common. For some reason, I've seen a lot more partial thirds. Apoplexy, as you know, can kill you. Pituitary gland, super important, and you kind of need that cortisol. If you don't have it, you die. An emergent CT scan of the sella is recommended, but an MR is a superior study. In the MR talks, we'll talk more about this, but you can see on this study the hyperintense signal intensity surrounding the suprasellar mass, and the chiasm there is being worn as a hat. But you don't have your pointer there with you still, do you? This is the important thing I want to mention to you about pituitary apoplexy. This is from the neurosurgical literature from Semple et al. 62 patients with an average age of 51. Oh, it just died, Peter. Oh, good. Average time to presentation, 14 days after the ictus, and I found that to be a very common presentation to me as well. The pain event, the sentinel event, was within a week or 2 weeks, severe pain, and then it lets up a little bit, presumably because the edema shrinks down, etc. 81% of the patients, no prior history of pituitary tumor, so you cannot rely upon the presence or absence of pituitary tumor for apoplexy. And as I mentioned before, even though headache is the thing that's in the books, only 87% of this cohort had headache, and diminished acuity was present in more than half the cases, 56%. So these patients will come to the ophthalmologist. Bitemporal hemianopsia, however, was only 1/3 of the cohort. So in other words, even though bitemporal hemianopsia is the classic book teaching for pituitary apoplexy, it is not the most common presentation. It's the most common of the patients that present, but it can be anything, optic neuropathy and diplopia. Interestingly, 73% of the patients hypopituitarism, 8% diabetes insipidus. These two things can kill you. This is a 35-year-old white male with diabetes, history of diabetic acidosis, new onset ophthalmoplegia, almost complete on the left with ptosis. So normally in a diabetic, we're thinking diabetic palsies. But the thing you should know about diabetic palsies is you're only allowed to have one cranial neuropathy at a time. So if you have more than one cranial neuropathy, it's pretty much badness. So there are cases of diabetics having multiple cranial neuropathy. I think Dr. Zitkowski actually published something on this. But I do not accept bilateral or more than one cranial nerve at a time for diabetic palsies. The life-threatening diagnosis in a diabetic who has ophthalmoplegia and pain acutely is mucor, fungus abscess. And the dangerous thing about this is, if you don't tell the radiologist that you're looking for mucor, this sphenoid sinus opacification will be read out as sphenoid sinus disease. And they may not comment on the adjacent cavernous sinus fullness unless you tell them, look, this patient's a diabetic and we're looking for mucor. Please look for mucor. And the problem, of course, is the sinus is directly adjacent to the cavernous sinus. So when you have mucor, fungus, or aspergillus in your sinus and it goes into the adjacent cavernous sinus, you will get an ophthalmoplegia from involvement of the third, fourth, or sixth nerve. And the dangerous part, life-threatening part, is big red. The internal carotid artery lives right there, and so adjacent vasculitis can cause stroke and death. And in the book, it always says this: look for this black eschar thing. This black eschar is necrosis. It is the end stage. By the time you see the black eschar, game over. That eye is going to exent. So please don't wait for the black eschar. Even if ENT comes back and says, we looked up the nose, we saw no black eschar, that means nothing. The second thing I want to emphasize to you is that even though mucormycosis is the book answer, aspergillosis, in my opinion, is way more common. The survival rates from solid organ transplantation and the number of patients on chronic immunosuppression with chronic steroids and chronic immunosuppressive agents is increasing in our country and yours too, and those lead to predispositions for aspergillosis. Many patients with aspergillosis don't have any risk factor either. It lives in people just sitting there waiting to come out. So how could you miss this fungal orbital apex mass on MR? Well, there's three things that you need to know, and we're going to talk about that more in the MR talk. You need to have contrast material in order to see enhancement rather fungi, and fungi don't have any water in them. Fungal hyphae will be dark on MR. And if you don't put fat suppression, you will totally miss the lesion if it's in the orbit. And the reason this is super dangerous is acute painful ophthalmoplegia, there is this idiopathic syndrome called the Tolosa-Hunt syndrome. In my practice, the Tolosa-Hunt syndrome is super rare. Most of the patients referred to me as Tolosa-Hunt are Tolosa-not. And the thing I'm worried about is fungus. And if you give fungus steroids, you just kill them. The other thing, of course, is retrobulbar optic neuritis. Optic neuritis treatment trial, we're telling you to give steroids. Yes, that's true, but if it's fungus, you killed the person if it's fungus. So look at this. This is the dangerous part. If you don't give the contrast, you will not see the abnormality, which is right there. See the contrast enhancement along the orbital apex, and it's a very small amount of badness, but in a very tight space. So if you have abnormal enhancement in the orbital apex, you can get an optic neuropathy or an ophthalmoplegia or both. But the key and differentiating feature, the thing for the radiologist to comment on is this, the adjacent sinus disease. So the adjacent sinus disease is the key radiographic feature. And it does not have to be prominent. This whole sinus could be chock full of fungal hyphae and it would be dark on MR. And the only abnormal enhancement is this part, adjacent to, yes, the orbital apex enhancement. And this always makes its ways to the Royal Society meeting because of this exact same problem. It's hard to pick up on the first initial MR scans. So what you need to do is you need to tell the radiologist, this patient has an optic neuropathy and they're diabetic, or an ophthalmoplegia and they're diabetic. I'm worried about the orbital apex. Please comment about the sinus. Because if you don't, a radiology report will read there's adjacent sinus disease, and there's some enhancement in the orbital apex, and it might come back. Tolosa-Hunt syndrome is on the differential diagnosis. Then you're attempted to give the steroids, and you know the rest of the story. So, tell them you're looking for mucor, and they'll tell you that the sinus enhancement they're seeing is adjacent to the disease. The other thing I want to mention to you, which we will cover again in the radiology talks, is CT scan is much better for looking at sinus disease than MR, even though MR is better for orbital apex. Look at this MR. It shows that it's black, okay? But the same day, the CT scan of the same sinus, that's black sinus is chock full of fungal hyphae that are completely black on the MR because fungal hyphae generate no signal on MR. So CT and MR have complementary roles in the evaluation of fungal sinusitis, in this case mucor. So you need to have high suspicion and order the appropriate studies. 60-year-old diabetic man, new-onset ptosis, adduction elevation and depression deficit, 45 prison dioptric exotropia. Diagnosis, ischemic third nerve palsy. Plan, return 6 weeks. What's missing from the evaluation? The pupil exam. And you say, come on, who doesn't check the pupil? I can tell you, I see this exact scenario, no pupil exam, about once every 3 to 4 months, and it comes from my own retina service because they don't look at the pupil. The techs dilate everybody because they're interested in looking at the retina. So the behavior change I'd like you to make is you should tell your technicians that if the patient's complaint is double vision or ptosis, or if they have to lift up a ptotic lid to put the dilating drops in, please stop and come get me before doing this. Let me look at that pupil. So an acute pupil-involved third nerve palsy, the life-threatening diagnosis, of course, is aneurysm. And that's the rule of a pupil. Pupil-involved third is an aneurysm of the posterior communicating artery until proven otherwise. And here's the MRA showing the jalapeno pepper coming off of the PCOM IC8 junction. And this is the same patient who's had coil placed into the aneurysm. That's a cure, go home date 2. This is the highest stakes encounter in ophthalmology in your career. On average, you will do this once in your career. You get to make the decision. Is this third nerve palsy a vasculopathic diabetic third? Live, happy. Or is it a aneurysm, which is going to rupture and kill this patient in the next 29 days, or leave them permanently or irreversibly neurologically scarred? Half the cases. Half the patients who have subarachnoid hemorrhage don't make it to the hospital. They just die at the scene. The other half who make it, half of them are neurologically impaired. So you have a chance to make a difference in this person's life. And the imaging paradigm has changed a little bit. We're going to talk a little bit more about this in the imaging talk. But my first-line study for third nerve palsy is now non-contrast CT, looking for subarachnoid hemorrhage, and then contrast CTA to look for aneurysm. Then, if that's negative, I'm going to do an MRI, MRA as a second study. If in your institution MR is better, you could reverse the order. MRI, MRA, followed by CTA. MRI, as you know, is better for non-aneurysmal causes of third nerve palsy, so you're kind of stuck with both things. A catheter angiogram is probably not necessary for the vast majority of patients, except those with high clinical suspicion for aneurysm, or if you don't believe your MRA and CTA combination is of sufficient quality to rule out aneurysm, then you're going to be stuck with a catheter angiogram. But in the United States, rapidly CTA, MRI, MRA combination is obviating the need for catheter angiogram. And I just want to end with vertebral artery dissection. Vertebral artery dissection can lead to thromboembolic disease at the top of the basilar. And they can present with acute homonymous hemianopsia from PCA involvement or a bilateral and progressive ophthalmoplegia. Typically, by the time it reaches the top of the basilar, they have other brainstem syndrome, paresthesia, paralysis, etc. But the thing that I want to mention to you is the initial MR may be normal, so structural MR may be normal, and the diffusion weighted image will show evolving infarct. We're going to talk about DWI and the other imaging talk, but what I want to emphasize to you is an acute, progressive, bilateral ophthalmoplegia. One of the things on the list is brainstem disease, and one of the things on the acute brainstem disease is top of the basilar. And vertebral dissection can occur from trauma or be spontaneous, and the thing we want to prevent is the propagation of the emboli and the development of the top of the basilar full-blown syndrome. And just like with the carotid dissections, what we're looking for is a crescent sign, this little crescent of hyperintense signal intensity surrounding the flow void, in this case surrounding the vertebral artery, and in this case there's an adjacent DWI abnormality in the lateral medulla. So the dissected segment can flow emboli and you can get progressive thrombosis. In our institution, if they identify the thrombosis, they'll probably undergo thrombolysis therapy. And I'm going to talk more about the fusion wave image, but this just shows the DWI abnormality showing the hyperacute infarct, no flow in the basilar, and then before and after thrombolysis therapy. The bottom line is, on all of these conditions, it's your job to make sure it's not a life-threatening etiology. So you're going along, seeing the cataracts, and what was that third nerve palsy thing? Scrape that sucker off. So these are Lees-P's. Pain, especially the acute onset, severe pain in the elderly, that's giant cell. Perception loss, that's optic neuropathy, that's orbital apex involvement until proven otherwise, mucor abscess in a diabetic. Pupil involvement, that's third nerve palsy. Progressive proptosis, that's orbital apex as well, mucor or aspergillus, more commonly in my experience. And if you have progressive bilateral ophthalmoplegia with or without paresthesias or paralysis, you should be thinking about top of the basilar syndrome and vertebral dissection. So if you know those A's, arteritis, apoplexy, aneurysm, you heard about amaurosis yesterday, you know the things that kill people with diplopia. Thank you for your time and attention.